I will be presenting the obturating techniques in root canal treatment. It would be covered under the following contents. Introduction, ideal requirements of root canal filling material, gutta-percha, obturation technique, lateral compaction, vertical compaction, sectional condensation, compaction, thermoplasticized GP technique, chemically plasticized GP technique, conclusion and references. The objective of obturating the root canal is the substitution of an inert filling in the space previously occupied by the pulp tissue to prevent recurring infection by way of the circulation or through a break in the integrity of the crown of the tooth. Now, Grossman requirements for an ideal root canal filling material. First, the material should be easily introduced into the canal. Second, it should seal the canal laterally as well as apically. Third, it should not shrink after being inserted. Fourth, it should set slowly. Fifth, it should be impervious to the moisture. And last, it should be bactericidal or at least should discourage the growth of bacteria. Timing of obturation. Factors influencing the appropriate time to obturate a tooth or patient signs and symptoms, pulp and periradicular status, degree of difficulty, and patient management. Coming on to the vital pulp tissue, removal of normal or inflamed pulp tissue and performance of the procedure under aseptic conditions should result in a successful outcome because of the absence of bacterial contamination. Obturation at the initial visit also precludes contamination as a result of leakage during the period between patient visits. When pain occurs as the result of irreversible pulpitis, obturation can occur at the initial visit, since removal of the vital tissue will generally resolve the patient's pain. Necrotic pulp tissue. Patients who present with pulp necrosis with or without asymptomatic periapical pathosis may be treated in one visit nowadays. When patients present with acute symptoms caused by pulp necrosis and acute periradicular abscess, obturation is generally delayed until the patient is asymptomatic. Procedural concerns also dictate the time of obturation. Difficult cases may require more time for preparation and can be managed more uneventually in multiple appointments. Patient may require multiple short appointments because of medical conditions, their psychological state of mind and fatigue. Coming on to the techniques of obturation, according to the Grossman, lateral condensation, vertical condensation, sectional condensation, compaction, by Max Padden technique, thermoplasticized GP technique, last chemically plasticized GP. First, Foucault lateral compaction technique. In this technique, it is one of the most commonly practiced obturation technique. However, in contemporary endodontics, it is not the best technique to achieve a 3D seal. Clinical consideration. Sealer consideration. Sealer application on the canal walls can also be performed using a lentillo spiral or with the master gutta-percha cone itself. Master cone considerations. Selection of the master cone should be similar to the master apical file cells. Minimal judicious force should be used on the spreader during the compaction process in order to avoid root fractures. Additional secondary cones are inserted until the spreader cannot be reinserted, an indication that the root canal is fully compacted laterally. A cement coating is not mandatory for secondary cones. Warm compaction method, warm GP, warm vertical compaction. Coming on to the principle, the warm vertical condensation or warm GP technique of the root filling root canals was introduced by Schroeder with the objective of filling the main root canal as well as lateral or accessory canals. Using heat pluggers, one applies pressure in a vertical direction to the heat softened GP and thereby causes it to flow and to fill the entire lumen of the canal. Indications. As an alternative to the cold compaction technique, when the filling of a conventional master cone to the apical portion of a canal is impossible, then there is a ledge formation, perforation, or unusual canal curvature, internal resorptions, or large lateral canals. Coming on to the technique. This step in warm vertical compaction are as follows. A primary non-standardized or greater taper GP cone corresponding to the last instrument used is fitted in the canal in the usual manner. The canal wall is coated with a thin layer of root canal sealer. The primary GP cone or master cone is inserted up to the working length. The coronal end of the cone is cut off with a heated instrument. A heat carrier, such as root canal plugger, is heated to redness and is immediately forced into the coronal third of the GP. Disadvantage: the amount of time it takes, the risk of vertical root fracture resulting from undue force, periodic overfilling with GP or sealer that cannot be retrieved from the periradical tissues. Warm vertical compaction is difficult in curved canals where the rigid pluggers are unable to penetrate to the necessary depth. To compensate for the rigid carriers to penetrate within 4 to 5 mm from the apex, the canals must be enlarged and more tapered in comparison with the lateral compaction technique. Excessive removal of tooth structure weakens the tooth. Coming on to the warm lateral compaction, this technique provides an advantage inherent to thermoplastic technique as well as length control during obturation. The technique involves placement of master cone and lateral compaction using heat carriers such as endotech 2 tips and endo twin tips. The device is placed beside the master cone and activated, followed by placement of an unheated spreader in the space previously occupied by the heat carrier. Accessory cones are then placed and the process repeated until the canal is filled. The technique involves adapting a master cone in the same manner as well as lateral compaction. An appropriate size Endotech 2 tip is selected. The Endotech 2 are available in various tapers and tip diameters. The size consists of 0.2%, 30, 5%, 30, 2%, 40, etc. The device is activated and the tip inserted beside the master cone to within 2 to 4 mm of the apex using light pressure. The tip is rotated for 5 to 8 seconds and removed cool. An unheated spreader can be placed in the channel created to ensure adaptation and an accessory cone placed. The process is continued until the canal is filled. Continuous wave compaction technique. The principle involves the variation of a warm lateral compaction technique introduced by Bushing. The technique employs the use of gutta-percha cones and pluggers that mimic the tapered preparation, thereby permitting the application of greater hydraulic force during warm compaction. Continuous wave compaction uses tapered night systems to prepare the canal. Pluggers are selected in consistence with the size of shaping instrument used. Tapered pluggers such as 6%, 8.8%, 0.10, etc. with a tip diameter similar to tapered GP points respectively are employed. The procedure is carried out with a heat carrier system. This is the diagram showing the warm compaction. Thermoplasticized GP injection technique. Principle. This technique comprises a pressure apparatus consisting of an insulated electrically heat syringe barrel and a selection of needles ranging from 18 to 25 gauge size. The plugger is designed to prevent backward flow of the GP. The degree of heat is regulated to provide proper exclusion of the GP according to the size of needle. Technique involves the apical terminus should be as small as possible to prevent extrusion of GP. The technique requires the use of sealer, and once the canal is dried, the canal walls are coated with sealer using the last file used to length or a paper point. Gutta-percha is preheated in the gun and the needle is positioned in the canal so that it reaches within 3 to 5 mm of the apical preparation. Gutta-percha is then gradually passively injected by squeezing the trigger of the gun. The needle backs out of the canal as the apical portion is filled. Pluggers dipped in alcohol are used to compact the gutta-percha. The segmental technique may also be used in which 3 to 4 mm segments of gutta-percha are sequentially injected and compacted. Coming on to the ultrafill 3D. Ultrafill 3D is a thermoplasticized gutta-percha injection technique which involves the gutta-percha cannulus, a heating unit and a injection syringe. The system employs 3 types of gutta-percha cannulas. The regular set is a low viscosity material that requires 30 minutes to set. The firm set is also a low viscosity material that differs and it sets in 4 minutes. Cannulas can be disinfected but are not designed for heat sterilization procedures. Heating time varies, but for a cold it takes about 10 to 15 minutes. In a warm heater, it is recommended time is 3 minutes. After removal of the cannula from the heater, the needle should be placed on a hot part of the heater for several seconds. The gutta-percha remains able to flow for 45 to 60 seconds, depends on the viscosity. Limitations of this of it is one common defect in all injection technique is the lack of precision in delivering the gutta percha near the apical foramen and not beyond. Though it may fill the canal literally in all it, you know, Thermophil thermoplasticized technique. Thermophil is a carrier-based GP obturation system comprising a plastic cone barrier carrier coated with alpha phase GP. Advantages of it are easy placement and pliable properties of gutta percha. Disadvantages include metallic core made placement of a post challenging and retreatment procedures are difficult. In addition, GP was often stripped from the carrier, leaving the carrier as the obturating material in the apical area of the canal. Thermophils are available in ISO standard sizes as well as variable tapered sizes suitable for canals prepared with nitide-tapered instruments. These obturators are used in conjunction with the heating device known as thermoplap plus oven. Technique involves after preparation of the canal with suitable instruments. The size of canal is assessed with a thermophil verifier instrument which help in the selection of the appropriate size obturator. The canals are dried and coated with sealant. The silicone stopper on the carrier is adjusted to the working length and the carrier is loaded into the thermoprep plus oven for approximately 10 seconds. The carrier is then inserted into the canal and placed up to the working length with a firm, uniform apical pressure without rotating. The position of the carrier is verified radiographically and the GP is allowed to cool for 2 to 4 minutes before resecting the carrier at the level of the canal orifice. This is a figure showing the thermophil carrier and the size verifier. Thermophil carrier is placed into the distal canal. Vertical compaction of the coronal gutta percha can be accomplished. When necessary, gutta percha can be added, heat softened and compacted. An advantage to this technique is the movement of gutta percha into lateral and accessory canals. However, extrusion of material beyond the apical extent of the preparation is a disadvantage. Simple fill sectional obturation technique. SimpliFill is a carrier-based sectional GP obturation system used in conjunction with a light-speed rotary instrumentation. SimpliFill is manufactured for use following canal preparation with light-speed instrument. The carrier has an apical plug with a 5 mm of gutta percha. The technique involves in fitting a carrier that is consistent with the master apical rotary file to within 1 to 3 mm of the prepared. Advantages are economy of time, ease of selection and insertion of GP cones, rapid filling of canals apically and laterally, including irregular spaces within the canal if one uses a sealer. Disadvantages include inability to use the technique in narrow canals, frequent breakage of compactor blades, frequent overfilling of the canal, shrinkage of the cold set filling. Coming on to the chemically plasticized GP technique, GP can be plasticized by chemical such as chloroform, eucalyptol, or xylol. The disadvantage of using a chemical solvent filling material is its inability to control filling, which resultant periapical tissue reaction and shrinkage of the filling after setting, resulting in a poor apical and lateral seal. Chemically plasticized GP technique is no longer recommended. Immediate obturation. Apical barriers may be necessary in cases with immature apical development, cases with external apical root resorption, and cases where instrumentation extends beyond the confines of the root. Dentine chips, calcium hydroxide, demineralized dentine, lyophilized bone, tricalcium phosphate, hydroxyapatite, and collagen have been advocated for placement as a barrier in canals exhibiting an open apex. The barriers are designed to permit obturation without extrusion of materials into the periradicular tissues, but often incomplete and do not seal the canal. Dentine chips appear to confine materials to the canal space during instrumentation and may encourage development of a biologic seal, enhance healing, minimal inflammation, and apical cementation deposition have been noted histologically. A concern with this technique is contamination of the dentine with bacteria because investigators found infected dentine adversely affected healing. Calcium hydroxide has also extensively used as common apical barrier. Calcium hydroxide has shown to induce an apical barrier in epexification procedures. Calcification similar to dentine plugs have been noted at the apical foramen. Calcium hydroxide has the advantage of being free of bacterial contamination and may provide a better, although imperfect, apical seal. Immature teeth exhibiting pulp necrosis or teeth with apical resorption. Traditionally, were treated with calcium hydroxide to establish an apical barrier before obturation. A recent study demonstrated teeth treated with calcium hydroxide for prolonged periods are more susceptible to fracture. Immediate obturation is an alternative to apexification. An apical barrier material should confine obturation materials to the canal space and enhance healing by inducing cementum and bone formation. MT is sterile, biocompatible, and capable of inducing hard tissue formation. The technique has been shown to be clinically successful and can be accomplished quickly, eliminating the need for numerous visits and possible recontamination during the months required for apexification. This is a pro root MTM material, the root canal repair material. Thank you.